Hello, this is Dr. Hansen, Carl Hansen. Today we're going to bring a topic on statin drugs for the treatment of cholesterol. Should you be on a statin drug? Are you on one and should you continue that? First off, this isn't medical advice, and anything concerning your health, your medication should be brought to your primary care physician and or any other physician you have to discuss this in detail, because tailoring medical treatment is really to the individual and should not be done on a population basis. The question is, should you be on a statin, or should anybody be on a statin? Why be on a statin anyway? Well, it is felt that if you have a high risk for cardiac disease, and if one of those risks is an elevated cholesterol, that if you take a statin, you reduce your risk of heart disease. So what does that mean? The big risk factors for heart disease, in other words, the conditions that a person has that might predispose them to angina or heart attack or stroke, etc. Number one would be tobacco use, cigarette smoking. Clearly the biggest risk factor, and nobody should be smoking. The second would be uncontrolled high blood pressure. If you've had high blood pressure over many years and it's never been controlled, your arteries get kind of stiff and plaquey. The third thing would be diabetes, especially uncontrolled diabetes. But if you've had diabetes for a long time, that in and of itself is a risk factor for heart disease and heart attacks and strokes. Another one is a genetic component, and there are certain people that have a strong genetic history. Now, that does not mean, though, that if your dad or your granddad have a heart attack, that you're more likely to. Because if your granddad and your granddad were smokers, but you're not, the reason, though, they probably had heart attacks was because they smoked, not because of genetics, but just because they smoked. And if you don't smoke, therefore, you're probably safe. And then the last risk factor, the fifth, would be elevated cholesterol. It is felt by many that elevated cholesterol is a risk factor for heart disease and strokes. And I would agree to that, to say that people who have a genetic elevation of their cholesterol, a familial hyperlipidemia, also do have an elevated risk of heart attack and stroke. But what about people that don't have that genetic issue? The data does not suggest that statins are any benefit, that we should be treating people with statins. And you could take this a bit further. If you really look at the studies over the many years, the statins have shown precious little impact on actual heart disease. By that, I mean, many studies on statins show that they have no benefit, but there are some studies that show they have some benefit preventing heart disease. Without going into the studies, again, many do not show any causal relationship with reduction of heart disease. The ones that do require that you have to treat a lot of people in order to see any effect. There's a statistic that often comes out in a study that talks about its drug's effectiveness or its relative risk reduction. Those are marketing ploys in a way. For a study, you really have to look at something called absolute risk reduction. And I've covered this a while back, but just know ARR is what you look at. If you take the inverse, in other words, 1 over ARR, you have a number now called NNT, or number needed to treat. So it is not unusual for these statins, of which there's many, to have an NNT of 40 or even 50. That is to say, over the course of a study that they're doing to check out a particular drug, let's say that goes 5 years, that in order to prevent one heart attack or one stroke, etc., they would have to treat between 40 and 50 people for those 5 years, for them taking. You can say, well, that's one prevention is better than nothing. And I guess that's logically true, but practically that's not true. If you have to treat 50 people for 5 years to accomplish one event, it's questionable really how effective this is. You can take a study and populate it with enough study participants, and you can come up with a lot of interesting conclusions. I think 2019, 2020, 2021, and now We have learned to be thoroughly cynical about many medical studies. So many medical studies are probably tainted. And for these statin medicines not to have any clear benefit in most people, the mechanism of action of statins is that it interferes with an enzyme that is involved in the eventual creation of cholesterol. Now, cholesterol is a molecule that's vital for animal function. It makes up the walls of the billion cells we have in our body. It's the precursor to steroids, to testosterone, to estrogens, etc. So cholesterol is an important molecule that's manufactured typically in the liver. But we feel that if we can block its production, that we will prevent heart disease. Intuitively, that makes sense when you see all the plaque, cholesterol embedded in plaque. But funny thing is that the studies on statins and cholesterol don't find that tight a correlation between cholesterol level and heart attack or stroke risk. I mentioned one mechanism of action is blocking the development of cholesterol. But as with any chemical we ingest, yeah, there's one mechanism of action, but there also are probably other several things that this chemical is doing within the body, some of which could be adverse and actually cause problems. We don't really know what the statins can completely do. One thing that does seem to kind of shake out from some of the data is that statins have a beneficial effect from the standpoint of reducing inflammation in the blood vessels and stabilizing plaque. In other words, keeping the plaque in an artery rather inert so it doesn't break, so it doesn't induce a clot, etc. So statins have some other mechanism of action, which is probably even more important than its cholesterol-lowering effect. No, however, though even in the studies that reflect that, the number needed to treat is extremely high. Make no mistake, there are plenty of patients that I treat with statins. I make that decision that if I feel somebody has a number of risk factors, if a person is a smoker and diabetic, I feel from my review of the data that it is worthwhile to at least entertain the thought of putting them on a statin. But I don't automatically put people on a statin just because their cholesterol is high. That's irresponsible. So if I'm doubting statins, one way to support that doubt is that there were a few statins on the market early on. We talk about Mevacor, Pravachol, and Zocor. Pravachol was the only one for a while that had any data that it could help prevent anything. And it was pretty weak data, but they had a large enough population size. That was the West of Scotland study. So there is data out there. Then Pfizer came out with Lipitor, which boasted as being the most potent LDL lowering drug. LDL, by the way, is considered the bad cholesterol. Most potent LDL lowering drug out there. And so its market sales took off. Now, I didn't use Lipitor for a few years because Lipitor had no data suggesting that they did anything good. Yeah, they brought down cholesterol numbers, but I don't do what I do simply to bring down numbers. We do what we do to extend lives, make people's lives better, etc. So Lipitor never had that data, atorvastatin. And as a matter of fact, when atorvastatin and Lipitor finally came out with that data, with some outcomes data, it was pretty lame as far as an indication, but it sort of reinforced people's impression that it was a great drug. So you may ask, Dr. Hansen, well, with all that, why do you still prescribe statins at all? Well, number one, I feel that in high-risk people, they do have some anti-inflammatory effect and plaque stabilizing effect. I feel that way independent of a person's absolute cholesterol number. I still would much rather prefer people treat themselves with diet, exercise, etc. But there are individuals out there who I feel that they would benefit. Now, you say I cited studies. If a study says that the study reduces the chance of a stroke by 25%, 25% reduction, that doesn't mean that I can say if you take this drug, you will have a 25% less chance of a heart attack. You can't do that. To take a study where there's N equals 10,000 patients, to now reduce that down to one individual where N equals 1, and tell that one person that because the study across the population reduced heart attacks by 25%, let's say, that this drug will do this for you. You can't do that. If anybody tells you that, they don't understand statistics whatsoever. If a patient asks me, all I can say is that in a study, it reduces the chance of a heart attack by 20%, for example. But that sounds really great, but reducing by 25% is not that great because I'm giving what the pharmaceutical industry feeds me is the relative risk reduction. When I go to the ARR and then convert that to number needed to treat, then the numbers look usually pitiful. Dr. Carl, what's another reason? So you feel like that some people actually, the statins can reduce inflammation and stabilize plaque. I do. And not because they interfere with cholesterol production. The mechanism of action is not known as to why I think it has this other benefit. Some may have this other beneficial effect in some people. Physicians are under peer pressure and guidelines. It's promulgated throughout the whole industry that statins are important. As a matter of fact, we have guidelines and algorithms that tell us that this is when we need to give a statin, that we should. That if we're not giving a statin in this particular case, then we're going outside of good medical practice. If we're not following the cookbook, if we're not obeying the American Heart Association on when to start treating, if we do that, there's considerable peer pressure. So if I want to act independently and say, hey, Mr. Jones, I know what all the guidelines say. I know what Cardiology Association says. I know what Diabetes Association says. But I reviewed the studies myself independently. I didn't need a committee of people meeting in Cancun or Bermuda to tell me their opinion. My opinion that these statins are not necessarily beneficial for you. Or if they are, their benefit likelihood is so small that there's a strong chance that the side effect issue could actually be greater than the potential benefit issue. And then myself and the patient, we weigh that decision. That's informed consent, that's shared decision making. But know that there are guidelines out there that tell physicians to use a statin in this case. Physicians used to be cats and lions. I think now we're more like sheep and lemmings, maybe in a lot of instances. And so a lot of physicians will just blindly follow those guidelines, partly because they'll feel the physicians will get in trouble. Let's say I don't put Mrs. Smith on a statin. Let's say 5 years from now, she has a heart attack. What's my liability? Should I have put Mrs. Smith on a statin 5 years earlier? Well, I didn't feel the literature supported it. A lot of other doctors don't feel the literature supported it. Maybe some guideline out there supported it. So now there's a problem from a medical legal standpoint and from a peer pressure standpoint that I did not put this person on a statin and a bad event happened. Well, we don't know that even if I put Mrs. Smith on a statin, that she still would not have had a heart attack. There's no way of knowing that. So you can't presume that had she started a statin, that we would have prevented anything. But physicians are under pressure to do this. And there's not a lot of independent-minded physicians out there. If a lot of times, if an independent physician expresses this to a larger body or committee, we're sort of laughed at. And we would be jeered down. Not that anybody presents data to the contrary, but there's just the expectation that you do what the party line says. But that's not medicine. Medicine, I don't treat the party, so I don't use the party line. I treat individuals, so we decide. Now, there may be a person that I tell somebody, I really think you need to start a statin. I don't know what's telling me this, but I just get this gut feeling that your chance of heart attack is relatively high and that I do feel that there's sufficient data to suggest, never prove, suggest that this medicine might be of some benefit for you. I would like you to take this. If the patient declines, then okay, we had that discussion. It was perfectly reasonable to make that choice on their own, but they don't want to follow a particular suggestion of a medicine I want to give them. So physicians are under pressure, and rarely is it patients that put us under pressure. That I think, and I've had people who want statins even though they don't have any risk factors. So that happens. Statins are probably an important drug in some people. I think that their effectiveness is way overblown. I think their side effect profile is real because remember, we don't know everything statin does chemically inside the human body. We know how it interferes with the production of cholesterol, but we don't know exactly. We know a few of the mechanisms of side effects, but we don't know everything it does. So again, if your doctor requests you take a statin, that's going to be between you and your physician. You can discuss that, pros and cons. Know that the studies that look at statins, which got their FDA approval, those studies are not overwhelmingly remarkable. And many of the studies that have failed never get published. That's especially true back in the old days, but it's still true now. So if you did a study on statins and it showed it did no good, a lot of times the study would just be in the garbage can. And you'd never come to the light of day. These medications are important in certain individuals. It'd be nice if we had a crystal ball to determine exactly which individual would benefit. We don't. But we certainly don't want to overuse these products because there is chances of side effects with any of these products, most of which are reversible. But some, I contend, we actually don't know the cause of the side effects. So I hope this helps a little bit. This is not going to help you decide whether to take a statin or not, but it gives you a little insight as to what goes on in our brains about trying to figure out what medicines to place on people and some of the rationale. And the fact that the decision, even though it's a black or white, yes or no decision, the decision is actually based on a lot of gray areas. We have to accept that. Try to think it through as much as you can. Anyway, I hope that gives a little insight into statin prescribing and statins in general without going into the chemistry, if you will. But anyway, thank you for listening, and I hope this helps some. All right, bye-bye. Bye now.